Okay, welcome to this podcast for Chapter 20 involving international healthcare services. There are 24 pages in the textbook that you need to look at and read. I want you to focus in on Table 21, which involves, that's two of those pages in the textbook. It's essentially a summary of health delivery systems around the world, the key aspects. Again, that's 2 pages. There are 21 slides in this particular podcast, and we'll get started here. Before we get started, just mention that Team 5 has been assigned to make a videotape case presentation for this chapter. The case at the beginning of the chapter involves Chloe, who's a pharmacy student working for the Department of Health and Human Services. She's been charged to evaluate healthcare systems in Canada, Germany, the United Kingdom, and Cuba. And again, this chapter addresses all of those. There are 5 objectives that we will cover as we go through this podcast. Again, there's 21 slides. We'll be covering 4 IRATs too, so you should have your outline printed out and ready to take some notes to prepare yourself for the IRAT after this. There are 4 broad models of healthcare around the world. There's the socialized insurance program. An example is Canada. There's the decentralized national health program. An example is Germany. It's called the Bismarck model. There's socialized medicine. The United Kingdom has the Beveridge model. You also see it in Cuba. That may sound odd, but the United Kingdom and Cuba are both examples of socialized medicine. And there's out-of-pocket that you see in a lot of the developing countries. I guess if I was to say which model does the United States fall into, probably most closely the Bismarck model in Germany. Although we do have Medicare and Medicaid similar to Canada. If we had Medicare for everybody, we would be essentially like Canada. There's developed and developing countries. Developed countries are high-income economies. They're mostly industrialized, capitalistic democracies. They have a strong health infrastructures, and they have positive health outcomes. Developing countries in the context of what we're talking about are low-income and middle-income economies, which constitutes about 85% of the world's population. It's also about 12% of the global world expenditures. Now, focusing first on Canada, it has a socialized insurance program, Medicare, just like origins, 1940s, Saskatchewan's government financed insurance for hospital service, and in 1966 was their Medical Care Act. There are 13 different health insurance plans that are associated with each of the provinces in Canada. So you have a different health insurance plan, like in Ontario versus British Columbia. Principles guiding the healthcare system in Canada are portability of benefits. You could take it with you from one part of the country to another. The comprehensiveness, the universality, the accessibility, and the public administration. The structure, the facilities, and the workforce. Oh, I'm sorry. I should have mentioned there's an IRAT from this particular slide. When you're looking at the principles guiding the healthcare system, I want you to know that when you're looking at the differences between the provision of health care in Canada and in the United States, I want you to know that the chances of being uninsured are higher in the United States than in Canada, which is part of these guiding healthcare system principles that help distinguish Canada from the United States, their healthcare system. Moving on, the structure of the facilities and workforce. Delivery is mostly private. Most hospitals are nonprofit community and teaching hospitals. About 4% of the hospitals belong to the federal government. And then there's health education. Financing, there's a global budget for hospital. There's a fee for service with a fee schedule with some capitation for physicians. There's limited coverage, which varies by province for drugs. There's some employer coverage. They are also, that's the current status, which can change, just like in the United States. Germany, the decentralized national health program, they have things called sickness funds. The origins, 1883, the health insurance system for manual industrial workers, instituted by Chancellor Bismarck. I forgot. There is a IRAT that comes from this particular slide involving Germany. I want you to know that Germany, in addition to Japan, represent examples of decentralized national health programs. They have those type of healthcare plans that are represent examples of decentralized national health programs. So Germany and Japan are similar in that respect. Okay, the principles guiding their healthcare system are self-governance, a social partnership, and social solidarity, where you have people working together. Structure, the facilities and workforce. Delivery is mostly private. There's a mix of public, private, nonprofit, and private for profit community hospitals. And there's health education as well. Financing in Germany. For hospital, it's on a case-per-case prospective budget, similar to our drug-related groups we have in this country. Physicians have a fee for service, which is negotiated, and drugs are covered through sickness funds, that meaning co-payments are required. And again, that's subject to change. United Kingdom, socialized medicine, the national health system. Its origins date back to 1946, right after World War II, with the National Health Service Act. Principles guiding their healthcare system: universality, like you saw with Canada, comprehensiveness, little charge at point of service, financing is through general taxation, and nationalization of hospitals. There will be an IRAT coming from this particular slide. And I want you to know, keep in mind Canada and United Kingdom, where Canada has a socialized insurance system, whereas United Kingdom has socialized medicine. That's a distinction I want you to understand. Canada, socialized insurance system, and United Kingdom is really socialized medicine. There's a big distinction there. Some people think it's the same. Structure, function, facilities and workforce in the UK. Delivery is mostly public, not private. Most hospitals are public and provide secondary and tertiary care. General practitioners provide primary care and act as gatekeepers to hospital care. And like the other countries we discussed thus far, there's health education provided. Financing for hospitals, there's an annual block contract. These HRGs, the physician, there's a mix of fee-for-service, capitation, and performance-related scheme. Drugs are covered through the National Health Service. And again, that's subject to change. Cuba, socialized medicine, origins, 1975, with the medicine and community program, and in 1985 with the family physician program. Principles guiding the healthcare system that I want you to know. There, healthcare is considered a right. Healthcare is the responsibility of the state. Preventative and curative services are integrated. Everyone participates in the function of the healthcare system, and healthcare activities are integrated with economic and social development. Financing, delivery is completely public. Hospitals provide tertiary care. Polyclinics provide secondary care. And community-based family physicians provide primary care. If you ever hear any seminar about healthcare in Cuba, they really focus in on these family physicians. They're really the backbone of the system the way it is run now. Financing, there's a national budget. Physicians are provided a salary, and drugs, there's a full coverage. From this slide, you will have an IRAT, comparisons of other countries with the United States. You see here, under the United States of America, it's characterized by less government involvement, more spending, less egalitarian distribution of resources. With other countries, there's generally more government involvement, meaning delivery. Like in Cuba, there's completely public healthcare delivery. And like in the UK, Canada, and Cuba, there's financing from annual budgets. Also in other countries, you see less spending, much less spending than you do here in the United States. And there's more egalitarian distribution of resources. So in this particular slide, I want you to understand that based on the healthcare system continuum, there's a sequence that lists the nations from the least government involved to the most government involved. Usually from the least government involvement is Cuba, under that is Canada, then under that is Germany, and the most government involved is United Kingdom. Now you might think, well, Cuba, there's a lot of government involvement. That's not true. If you go back to the slide that we talked about Cuba, everybody is involved in healthcare delivery. So Cuba has the least government involvement, followed by Canada, then Germany, and the most government involvement is United Kingdom. And that's important to understand. Okay. Now, with this slide is the end of the podcast. Thank you.